Probably the biggest research study this year was around this question of when do you start HIV treatment. And so this study was called the START study, and HIV doctors in research have really become difficult, and they make acronyms for everything. So they spend more time designing the acronym than they design the trial. So you see how they take all the letters, and that's how they come up with these things. And every trial has an acronym, and that's what makes them so difficult. So this thing was called the START study, and it was really, when should someone start HIV treatment? And why this trial was necessary is because our guidelines over the years keep changing. And our guidelines first said we don't treat anybody till they have AIDS. And then we got some drugs, and then we said, oh no, we're going to treat them when they have early HIV disease. And then the drugs got all toxic, and we said, oh no, we're going to hang off and not treat people until later. And then the drugs got better, and then we changed our minds. So we kept changing our minds based on the drugs and how well they worked and how toxic they were, rather than studies to tell us when to start. And so a lot of people would look at their clinics, and many clinics have databases, and I'm sure many of you have been asked to join the OCS database or your clinic database. And when people looked at the databases, it was sort of suggesting it was better to treat people earlier than later. But the problem when you just leave things to practice is people that decide to start treatment early are different than people who don't want to start early. And so that leads to what we call bias in our understanding of what's right. And so the best way to find out what is the best thing to do is to do a randomized controlled trial. And so what that means is that a computer decides who's going to do what, so that nobody has any choice in the whole thing. And that takes away the bias to help us learn how to do things best. And so this START study took people whose T counts were greater than 500. And when this START study began, we most of the time would not recommend HIV treatment for people with T counts over 500. Our guidelines at the time sort of suggested that you should start somewhere around 350 or 500. And then the people in the study got randomized to either you start right now or you wait till your T count dropped to 350, which was the guidelines at the time. So this study was huge, okay? There were 5,000 people around the world who participated in this trial. And the strength of a trial in which there's lots of people is you really can get a good answer. And so what the primary endpoint, what the study was designed to say is, did it make a difference in terms of survival, in terms of having complications of HIV, or having other complications like heart disease or liver disease or cancer or all these other things. So this is who participated in this study. And so you can see that about a third were from Europe, about 20% from Africa, about 10% from North America, 25% from South America, and smattering throughout the world. Canada didn't participate in this trial, and the reason we did not participate is that we had some other studies going on at the same time for the same patients, and we didn't think it was fair to kind of make patients choose between different trials, and that's why we didn't participate in this. So who did? On average, they were aged 36. 27% were women, which is good. Most of the time when we do these clinical trials, it's all gay white men, and then we can't decide whether the results apply to women or not. So this is pretty good that they got 27% women. And you can see that there were a variety of races that reflected where the study took place. In terms of how people may have gotten HIV, about half of the people in the trial were MSM, and about 40% got it probably through heterosexual intercourse. Most people had only known about their HIV for a year. So most people were sort of newly diagnosed and were not on treatment when they started this study. And like we're seeing again and again, and here's a take-home message tonight, too many people with HIV smoke. And even though they'd only known about it for a year, a third of people smoked, which has some important considerations when we think about some of the conditions that we're looking at that people may have gotten over the study. So where was the T count when people started? So this is the T count range, and this is the percentage of people. So a third of people had a T count between 500 and 600. About a third of people had a T count between 600 and 700. About 20% above 700, and the rest were even higher. So think back yourself. Would you have been part of this study when your T count was here, knowing what you did when you started treatment? So the way we get answers to these studies is for volunteers to be a part of these studies so that we can learn. So where was their viral load at the time that people started? So the vast majority of people were here, which is a viral load between 30,000 and 300,000. And you can see that there were some that were higher and some that were lower. But overall, the average viral load was fairly low for people not on treatment, and it was probably, again, because most people had only been infected for about a year. So what happened? And so here's all these doctor charts now, and I'm going to try and walk you through them. This is time in months, and this is the percentage of people. So these red lines here are the people who started on HIV treatment. And as we would expect, they started on HIV treatment, and 90% of them got their viral load under 200 within 6 months. And that's what we expect when people start on HIV treatment. And then they stayed that way, which was really good news, as people were taking the treatment and consistently taking the treatment, and their viral load stayed up. The blue line here is the people who delayed their therapy. And as you can see, over time, the proportion of people who got their viral loads down increased slowly. And that's because as the trial went on, more and more people would have hit that low T count of 350 and started on treatment, and then their viral loads would go undetectable. And so on average, the people who were in the wait a bit arm, it was about 3 years that they waited before they went on to treatment. So what treatment did they take? And the other bad thing that doctors do is give every drug 3 different names and lots of letters and make it all confusing. This here is a tripla. That's this one here. So you can see that the vast majority of people who went on treatment went on a tripla because that's now the medication that the WHO suggests that most people in the world should start on in terms of treatment. What other treatments did they get? This group here got atazanavir, which is one of the protease inhibitors, together with Truvada. This group of people got AZT3TC and efavirenz. Now, we don't use that very much here in Canada, but clearly in much of the world, people are on that drug. So what happened to the T count? So again, here's the T count, 500 all the way up to 1,000. This is time. The red are the people who started treatment right away. And as you can see, their T counts went up. And after 60 months or 5 years, their T count went up by average up to around 950. So that was a really important lesson too, because before we didn't start people whose T counts were 700, which we consider normal. These people, despite having a normal CD4 count, still had an improvement in the T count. The people who did not go on treatment right away, so first their T count dropped, and then as they started to go on treatment, the T count rose. But the other interesting thing we learned here is that this group, despite the fact that they were now going on HIV treatment, never caught up. And their T count was here at 5 years, 200 lower than the people who started treatment right away. And of course, it's the T cells that are there to help your body prevent you from getting infection. So that was the second really important lesson that we learned. So, was it good? So here's the other kind of doctor plot we do. This is called a Kaplan-Meier plot, and it's one of the ways that we analyze data. And this is looking at the number of people over time that have the event, and again, this is time. So the blue line is the people who waited, the red line is the people who went on treatment right away. So what you can do is take an arbitrary point, so here at 48 weeks, 2.5% of the people who started right away had an endpoint compared to 5.3% who waited. So twice as many people who waited had an endpoint than people who went on treatment right away. And remember that endpoint was death, an HIV complication, or an organ disease. So twice as many who waited got this problem. So what were the problems? The biggest problem in terms of a difference between the groups was tuberculosis. So tuberculosis either in the lungs or in the rest of the body. So there were 20 in the group that waited compared to only 6 that went on treatment right away. And of course that reflects the fact that a lot of this study was being done in Africa, being done in South America, where there's way more tuberculosis than there is here in Canada. The other big thing was lymphoma. Lymphoma is a cancer of the lymph nodes that we can see in HIV. And again, 3 times as many got the lymphoma in the group that waited as opposed to the group that started right away. Kaposi sarcoma. Again, it's not something we see a whole lot of anymore, but it's the skin cancer that we see in HIV, 10 times higher in the group who waited. PCP, that's the pneumonia that we see in HIV, almost 5 times higher. So you can see that all of these complications occurred more frequently in the group who waited. But, sometimes doctors and patients will say, well, tuberculosis isn't a huge big problem for me. I come from a different part of the world. What about other things? Cancers that aren't associated with HIV. There were twice as many in the group who waited as opposed to the group who went ahead right away. And if we look at death, twice as many deaths. So what this study told us is that people who went on treatment right away were less likely to die, less likely to get an HIV event, less likely to get cancer, and less likely to get some of these other organ diseases. So this trial was supposed to go on for a lot longer, but when the safety board saw this data, they said we got to stop it, and we now have to offer everybody in the trial to go on HIV treatment. So for me in my practice, we don't see a lot of tuberculosis, but this is the factor now. If cancer is going to happen a half or a third as often if you start on HIV treatment right away, that sounds like a pretty powerful argument to go on treatment, especially as our treatments have gotten less toxic than they were in the past.